So they'll describe it in different ways. Generally, it's really important to find out whether the tinnitus has just started or whether they have an underlying tinnitus anyway. A lot of people say, oh, I've had tinnitus for the last few years, it came on when I worked in a factory, or it came on after I had a bereavement, or lots of different reasons why it might suddenly start. But they'll describe it in lots of different ways. So on our form, it actually asks, and our consent form, it asks whether they have a tinnitus already, basically, because it's really important to establish that, because you cannot ever cure them of their underlying tinnitus. You might reduce the sounds that they're hearing because the wax can compound that, but you are never going to stop it altogether. But there are patients that will come into you that have really blocked ears that say, I've suddenly started getting this whistling, this singing, this knocking, this crackling, this whatever noise. And the moment you take the wax out for them, oh, that whistling noise is gone. So those are the patients that, yes, that faux tinnitus, because it's not true tinnitus, it's just a temporary interference noise they're getting because they're so blocked in their canal and the TM's being affected.
I've heard the opposite as well can also happen. So you can have blocked, quite severely blocked with earwax, and then all of a sudden it's cleared. Now I've developed tinnitus.
Yes.
But I've read somewhere that they already had the tinnitus already, they've already had it, and when it was unblocked,
the brain's locked onto the noise.
Yeah. So you can also get...
You can get that.
Yeah, so that's
sometimes it will reduce down, sometimes they're left with it slightly audible. You can never say that you are never going to cause them to develop tinnitus with anything that you do in their ears. In days of old, when they syringed, a lot of patients did develop tinnitus for the very different reasons, whether it was cold water used, whether it was too hot water, whether it was done incorrectly and actually they were just firing against the TM continually, so you caused a permanent trauma to the TM. Lots of different reasons why tinnitus is caused from a trauma point of view, but it can, and I have known it, so as an audiologist that does earwax removal that I work quite closely with, and she had one patient in all the time she's been doing it who developed tinnitus post microsuction. So you can never say, and it's on our consent, that this is something that can happen. You can never say 100% that you are never going to cause this to happen. But like you say, the underlying issue was there in the first place. They just become more acutely aware of it, and the brain locks onto that noise. I'm talking about it, so now it's ringing like
I can
mad
hear it as well, since you said.
And when you're tired and stressed, and that's when you tend to have it really badly. So at night time, I've got into the terrible habit of having the TV on at night, or we have something playing in the background, because that distracts my brain from locking onto it. But I normally during the day have lots of noise around me. I've got the radio on, or I've got the machinery on in the clinic or whatever, and I can distract myself from it, but it's there all the time. As for some people it's one noise, for some people it's multiple noises, so I have a hee and a shh and boom, 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 boom. So I've got 3 different frequencies. There are apps that you can listen to or download that will actually play different frequencies, so you get a measure of what people are talking about. And I actually played it to my other half and said, these are the noises that I've got. He was horrified that that's what I've got going on in my head all the time. For some people it's so loud and it's so intrusive.
Locally to us, there's a tinnitus group in the hospital, and because my husband was referred to that, but he said he couldn't go because it made him worse. It made him more conscious of it.
For some people it is a problem. So there are different. So there's a good group called Otto.com. There's an app that you can download called Otto.com, OTO.com, and they are a group of audiologists, behavioural therapists, and ENT surgeons that have kind of clubbed together, and they've wanted to have an approach to managing tinnitus for patients. So they're private, but they've set up this group. There are lots of different management pathways for tinnitus, and some of them is cognitive behavioural therapy, some of it is hypnotherapy. There are lots of different things to try. From my perspective, what works for one patient won't necessarily work for another, so that's where you've got to try things. And I always say to my patients, look, it's worth going onto these patient forums and hearing what's working for people, because there might be something new that's come through that isn't out there in the mainstream. It's worth trying different things. People talk about diet, they talk about sleep and getting enough sleep and how that can impact on it as well. So, if you're like me and wait until you're literally nodding off before you can turn anything off so that you're not got that going on and annoying you, then it can really consume you. Sometimes I can understand why, I generally can understand why people actually find it really intrusive and problematic and affecting their life. It's miserable, but you've got to try and listen past it.
Yeah.
We all apparently have these noises that are happening, just our brain doesn't tune into it. And it's just for whatever reason, suddenly your brain starts to tune into it. My mum developed tinnitus really badly after my sister died, so and she's had it ever since. So it can be an emotional as well as a physical thing. It can be an obstruction or it can be viral. So there are lots of different reasons why it might happen. So you should never promise, the reason why I kind of labour this is you never promise you're going to cure somebody of their tinnitus if it's something they had before they came in to see you anyway and before their ears got blocked. But what you will probably do is reduce the amount of noise that they'll hear because the wax will have inevitably made it worse. And they will say, oh, it's much less than it was. But for some patients that only get those faux noises happening because of the impacted wax, then yes, they might just go, oh my God, it suddenly stopped. And it'll be that quick. Okay, so just be aware of that and be careful what you say to them. Oh, why has that gone off? Back to that. Right. So we are going to do some ear examination and very quickly show you. So generally, as a rule, there are different things that you can use to look in people's ears. Generally, as a rule, you'll be using something called an otoscope or loops to look in people's ears. There are things that you can get, devices that you can get that are like a camera device. So you just have an iPhone with on a stalk, and then you can look in the ears. We've got one next door, an endoscope that we use. Very, very expensive. We do everything freehand, and I train you to do it freehand. There are other devices like the Timper device and the iScope that you can go on training courses and spend an awful lot of money, and then have to spend an awful lot of money for your subscription to stay on their systems and to pay for the device. But there are other devices out there that are good. We tried the Timper device, we trialled it for 3 months, none of us could get on with it. It held us back with our practice and we found ourselves, I could not get a good view down the canal. Whether it's because I was so proficient already doing it freehand, I don't know, but I just couldn't get on with it. I wanted to, I just couldn't get on with it. So, and I've had quite a few people now on my course that have been trained with the Timper device that have either stopped it because it's too expensive or they've come on the course because they felt they couldn't use it properly. So, but it works very well for a lot of other people. They're using it. I'm not dissing the device at all, but it's not for everybody. And it is incredibly expensive. So you will have a really good view down the canal with your loops, but what I'm going to train you on first is how to effectively use, and some of you have already done this, effectively use an otoscope. So for those of you that have used it already, if you perhaps work with someone that hasn't, then at least it gives a good grounding on. So you two can work together, and if you three work with these three, that'd be great. If you actually use an otoscope, you have. Okay. We're going to use the otoscope first, but in terms of what you're going to see and what I want you to see landmarks of, you're not going to necessarily see all of this in these dummy heads, but you might see a little bit of it. You've got nice flat tympanic membrane. It's a kind of bluey grey colour. That's a really beautiful, you're not going to see that very often. In fact, you're very rarely going to see that because it's going to be obscured and occluded by the wax in the canal. And that's such a beautiful, healthy TM. No scarring on it, nothing, no discoloration, nothing. But you can see a good handler malleus, which is this point here. So that is the attachment point of where the 3 tympanic bones are in the middle ear canal. So when you're looking at it in the outer ear, that's where those 3 bones first attach. And then you've got a light reflex here as well. So this will be on the opposing side when you're looking in the other ear. So it will either be at, the handler malleus will be at 11 o'clock and the light reflex will be at 7 o'clock, or it will be at 2 o'clock and at 5 o'clock. So switch round the other side on the other ear. But as long as you can see that you've got a nice flat tympanic membrane that's a healthy colour, this kind of bluey grey colour, and slightly translucent, with a good light reflex and a handler malleus, that's what you need to see in terms of normal view of a TM. There are other things that you, if you looked really closely, you could see as well. But if I'm making notes in terms of if I see anything that's slightly unusual. Sometimes you might see some bubbles the other side of the TM, like some fluid or some air build up in the middle ear canal. Might actually physically see some bubbles, or you might see some discoloration. I will make note of it by using the clock face as my reference point. So if I saw some discoloration here, I'd say yellow discoloration seen 5 o'clock to 6 o'clock on the TM, so that anybody else looking in there that needs to know what I'm talking about, be able to see, bang, yep, there it is, 5 o'clock, there it is, I can see that too. So always use the clock face as a reference point when you're describing any anomaly that you might see on the TM. Likewise, if you saw a perforation, use the clock face to cite where it is. It could be you're going to say centrally, in line with 6 o'clock and 12 o'clock, centrally, there is a perforation of the TM. The side of the eardrum, the TM, nearest the face is the anterior aspect, and the side nearest the back of the head is the posterior aspect. Okay, so that's another good thing to remember as well. So this is intact and complete. There's no holes seen. It's nice flat colour. If it's retracted and sucked back, or if it's bulging, looking like a balloon being slightly blown up, then I would describe it as bulging or retracted. So you can see that it's, and that was in your pre-read as well, you can see that it's, the tone of it is different from how it should be, a nice relaxed flat shape. Your eardrum should be able to just gently vibrate, and then that cascades the sound into the middle ear and then onwards into the inner ear. If the wax is right up against it, it can't vibrate, so that's why you sometimes get these interference noises happening, because of that restriction and the change of pressure in the outer canal and versus the middle ear. Okay. So the reason why it might be slightly retracted is there might be a negative pressure in the middle ear. There might be some eustachian tube dysfunction. Your eustachian tube runs up from your back of your nose, it's this tube here, the back of your nose, back of your throat, into your middle ear. And when you've got a cough, cold, sore throat, anything like that, hay fever, anything where you're getting some more mucus building up, your eustachian tube can get a bit sticky and tacky, and then normally the valve that opens and shuts at the top of the eustachian tube to burp a little air bubble out to equalise that pressure, like when you're on the plane or in a tunnel and you go and it pops your ears. That's the equalisation of pressure in your middle ear. When that can't happen, people feel like their ears are full, and they'll come in and say, "Oh, I think my ears must be full of wax," and you're like, "No, nothing in there. Have you had a cough, cold, sore throat recently?" "Oh yeah, I have actually," or "I've had really bad hay fever." But invariably that's because the eustachian tube's not performing effectively, because it's got bunged up or a bit inflamed. So you will get this a lot, people presenting a lot thinking they've got a blocked ear and they haven't, it's because of the eustachian tube.
What would the advice be for that?
Advice would be steaming.
Steam.
And then if the steaming doesn't work, then to try some either some Beckenase nasal spray or some Titinus nasal spray.
Like the auto vents.
The auto vents, yeah. If it then doesn't clear, yeah, well, yeah, and if it doesn't clear, then you can get an auto vent. So you get a device that actually has a balloon device on it, and you isolate each nostril, and then that will help to exercise your eustachian tube by virtue of blowing through isolated nostrils. So that can go on to do that afterwards as well, if that doesn't work. You get so many, this time of year, people are getting these colds now. During the summer, horrendous hay fever during the summer, and everybody coming in and stuff. It would probably,
as well. Damp houses in winter.
Yeah. you probably get per week in clinic about 25% of patients that come and see us have got some degree of eustachian tube dysfunction. It's that much. Okay, so you want to see a nice, healthy, shiny, not very often that shiny, but shiny kind of eardrum, and you're going to use your specular to get a nice good view down the canal. I recommend using the metal specular rather than the plastic specular. I find you get a much good light rebound down the specular, so that actually you've got these black ones on your otoscope. When it comes to the loops, you're going to be using metal ones, and you see the difference. You get a much better light rebound, and it actually helps you actually compare it. So we're going to practice now on these dummy heads, okay? Again, just think about the handling of the ear.
Twice that then.
So underneath your tables, you have a stool. What you're going to need to be is your eye level is going to be level with the ear. Okay? Pull and twist.
Send me the link for these things, really.
You can get them on Amazon. You can look up Telecom School. I've got a couple of them in the car, but
I think you do house visits and stuff.
yeah. So you're probably going to be a bit too wide. So remember your. So in terms, can I just borrow that one a minute? In terms of holding the otoscope, those of you that already did this is going to be interesting. So you've got a wand, you've got a viewing piece, and a specular end with a light going through it. Okay, so you've got a light source, you've got a viewing piece, and a wand. The wand goes between your thumb and your index finger, and then you're almost holding it like a pen, and you're keeping your pinky out to brace against the face. Okay. Remember, you're going to look towards the nose, that's the direction of travel you're going to go in. So with an otoscope, you're having to get quite close to look down the viewing piece so that you actually can look down and see what's at the end. Is that right for you, isn't it? Yeah. It's the opacity. So you're going to hold it. Or you need to put a specular on the end to put all of these on.
Use a snake. I like it. How do you change the buttons and you can change the entire kit?
Change the view?
Yeah.
No, that's probably a Welsh Ellen, that's why. Right, okay, so you're holding it like this, and then with the finger out, the finger goes against the face. Okay, you're going to lift. So if everybody lifts their ears, if everybody could just lift their ears, so you're going to lift at the very tip of the ear, and you're going to lift. You need to lift upwards and backwards in terms of direction. That straightens the canal. Okay? Upwards and backwards. So, if you lift, everybody just do this with me. If you lift up and back, the very tip, that's a bit pinchy. And if you're going to hold on to that for a little while, you'll find yourself gripping quite fiercely because you're trying to get a good view down. But if you actually stick your finger underneath the kind of anti-helix, so you're going, instead of that, you're doing that. And you might get a much better control. I'll come around and do it on each of you.
Oh yeah,
So not that, you're doing that. You don't have to lift as quickly as that.
I see. So what are you supposed to do the second one?
Yes.
Okay.
So if you watch
Oh, I
that
see.
instead of that, it gives you better control and lift.
I don't know. The second one felt easier, didn't it?
Oh, no.
That's what you should do.
Yeah.
Oh, yeah.
Yeah.
Yes.
Yeah.
I'll do it
You
again.
do that instead of that.
Okay. What have you got in yours?
That. Okay, so upwards and backwards. So in terms of the place and specular in, you lift up and back first, you put the specular in, and you need to get it in quite far. It needs to go past the bony bit, because that's the uncomfortable bit.
What size? I was too big.
Bit of everything else.
It depends on the size of the canal.
Yes.
I've got the small, I think that's what five.
Have you both had a look in?
Yeah.
So, obviously, not to scope, you need to swap hands.
Get it in the ear.
When you
So
use your
your
lip,
hand like that.
you're not going
So they balance on the outside.
So you need to be able to dexterous for us.
Yeah. And then that comes
And is
on
there,
his
you can
face.
use either, I mean, when I've only
Get
ever
your
used
thing
push
in.
that, I've never used loops. Does it matter?
Yeah, and then
Is there-
Yeah, 100%. You might just
Oh, wow,
do
Yeah,
You've
that
got
was-
to use the loops.
Thank you.
Do you see what I mean now?
So I've got a small.
Rather than down.
So, it depends on the canal. The canal will change shape and diameter, so you need to use the corresponding shape and size.
We have a consultant that's using new ones, and they're actually, they're flat, but why do I think she gets them?
This morning, yeah.
but they're actually about that. But the tubes are only tiny. Yeah.
They don't cost a huge amount.
So, once you've had a look
Oh,
at
yeah,
it,
well,
once you've had a look on the dummy head, and remember, the reason why I ask you to use the stool is I want you to be eye level with the ear. So when you're looking in, please sit on the stool and get yourself eye level, because you'll get used to being at that height looking at someone's ear, okay? Otherwise you're going to end up punching, you're going to hurt your back, so I'm going to say to you throughout the whole day, you're too high on that stool. So you're going to do exactly, you're the physio in the room.
That was the worst.
She was saying that.
So, once you've had a look at the dummy heads, start having a look at each other. So now I'm going to come round and look at your ears as well. Okay?
My ears
It's mine, I'm like, I've cleaned ears, but I think I've got wax on going out. Show on that.